Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Good morning, George. It's Tuesday morning, and here we are once again doing the podcast.
Yeah, today we have a wonderful guest, Dr. Nelson Branco. Topic of discussion, the future of healthcare, the behavioral health integration into the pediatric medical home. So let me tell you a little bit about Dr. Bronco. He's a general pediatrician, just like us, with a strong commitment to behavioral health and community care. From the Navajo Nation to the Marin County, he's focused on supporting underserved populations and addressing the mental and emotional well-being of children. Dr. Bronco will share some insights of how he integrated behavioral health into the primary care setting and providing culturally informed pediatric care. Take it away. So, like we always start off, why did you become a pediatrician? It's a silly question, but everybody has a story.
Everyone has a story, and why I became a pediatrician relates a little bit to why I'm doing behavioral health integration in my practice. I went to school in Boston. I grew up in Massachusetts and southeastern Massachusetts, and went to BU for medical school. When I was a psychology major as an undergrad, loved psychology. I loved the field, and started medical school thinking maybe I'd be a psychiatrist until I did my psychiatry rotation. I realized that wasn't really what I liked. What I liked was behavioral developmental stuff. I liked back what we used to call the biopsychosocial model when I was at BU and working with folks like Barry Zuckerman and Bob Vinci and Ben Siegel. And I realized that I really liked pediatrics. I liked working with kids. I liked the medicine that we did in pediatrics. And so that's why I became a pediatrician. Came out to Oakland Children's, did my residency there. And then, as you mentioned, spent some time on the Navajo reservation working on the Navajo Nation in Shiprock, New Mexico, and something that I've continued to do a little bit. And ended up in Marin County, worked at a federally qualified health center for a bit, did the hospitalist thing for many years, worked in urgent care, and for the past almost 20 years of my current practice, Tamalpais Pediatrics, and working on building up our practice.
That must be some resume you have there. All we hear about is behavioral health. It's needed. It should be done. What does behavioral health integration mean in a pediatric office? What's the story?
Yeah. So behavioral health integration it's so many different things, right? We could spend the whole hour talking about all different ways you can do that. We all do behavioral health because we're pediatricians. And those of us who do primary care, we're taking care of kids. We're struggling with their mental health in various ways. We're supporting families. We're identifying postpartum depression in moms and dads, all sorts of things. And what we've done is we basically just increased the resources that we have in our practice. And so that's what we mean by behavioral health is we have folks who work with us, who are part of our team that help address mental health issues. So increase our resources and abilities.
So are those social workers, psychologists, physicians, NPs? Who runs the show?
Yeah. Yes to all, right? A part-time child psychiatrist. We're in the process of recruiting a psychiatric nurse practitioner. Those are our two prescribers who will do consultation and see patients and then refer them back to the primary care pediatrician. Let's see, right now, our current licensing is we have an LMFT, so a licensed marriage and family therapist, an LPCC, a licensed psychological counseling. Not sure exactly what the last C means. We have someone who is finishing up their hours to get their LCSW. So right now she's an ASW. All of the degrees work in the same way in our practice, and they provide therapy and support for the primary care pediatricians.
Yeah.
Let me ask you a few things about your practice. How many offices and how many pediatricians?
Yeah, great question. So right now we are 2 offices. We're located in Marin County, which is north of San Francisco. We're a suburb of San Francisco. Our practice is primarily commercially insured folk. And so we have some who are on Medicaid, which here in California is called Medi-Cal, but a pretty small percentage, and 2 offices, 9 pediatricians, 3 nurse practitioners, and then our behavioral health team is right now a half part-time child psychiatrist and 4 therapists. We also have a lactation consultant and a nutritionist who work with us.
So it might help that you have a lot of commercially insured patients. If you were 85% Medicaid, it might be incredibly hard to get these resources. And that's one of the things I really heavily criticize the AP about, talking about resources. Every apple is not the same. And unfortunately, if your apple is being funded by a program that pays 50% of Medicare, it is hard to find the resources to help these kids. Child exam, you got to treat the obesity, but they won't pay for the GLP-1s. No, that's off limits. You got to treat their depression, but you can't find a psychologist or a psychiatrist to see them because they just can't afford to see them for what Medicaid pays. And your options are to give them a little book to say, write down what was good about your day and come back in a week, and here's your Lexapro prescription. So it's key to have the resources to be able to do the work.
Well, and that's one of the things that I focus on when I give these talks, when I talk to folks about behavioral health integration. It's not one size fits all. We've been building this program for many years. And one thing I like to do is talk about our journey and how we got here. It's absolutely different in practices that have more Medicaid. And there are folks out there that we all know who are doing it in 5% Medicaid practices. Dr. Diasio in North Carolina is doing a lot of behavioral health integration. He and I have spoken on panels before. Dr. Gino in Cincinnati is doing it in a practice that has a lot more Medicaid than my practice. And what they do is they leverage the ability to get grants to fund some of their program, partner with local universities and training programs to provide services to kids. So you don't have to do it the same way we do it in our practice. And we started at the end as far as where we are now. I'm married to a therapist, LCSW.
That makes life easier.
No,
I'm sure she has a lot of friends that she can bring into work.
That's exactly right, George. What happened for us is we started our behavioral health integration by having her on she was a school counselor. And on the days that she wasn't at the school, she would do consultations for us. And there is a code that, and I'll share a link with you that you can put into the show notes, that folks can find a lot of resources that I have been sharing over the years. So she would meet with families, she would do some screening tests. And so one way to pay for some of this is all the extra 96127s and 96110s that you get from the PHQ-9s and the GAD-7s. And give families a curated list, right? Here are some therapists in our community that may have openings that I think would be a good fit for you, that have the right expertise. And it was way better than when I would give a list of 10 random names or refer them to a local program. That's how we started. That was our first step toward behavioral health integration. During the pandemic, she said, hey, my good friend Teresa, who's a school counselor at another local school, is looking to shift. And so we met and we said, I think you've got the knowledge and the experience to help us build what we're envisioning. And so while we hire you, and we hired one therapist who came on. And that was huge because not only was she able to continue doing the consultation and referral work, but she started providing some direct therapy. Took about 2 weeks and her schedule was totally overwhelmed, right? And we knew that we were going to have to shift to a different way of providing this care. But the point is, we had been doing a little bit at a time. At the same time, we found a local child psychiatrist and said, hey, can we hire you a couple of sessions a month to connect over lunch by Zoom? And we'll just present cases. And this is prior to our state having a statewide child psychiatry access programs. The advantage to us, we started our consultation session before that was available in California, but we were able to hear each other's cases. We were able to learn from her assessment of what we were seeing and what we were presenting. And so we increased our ability to keep those kids and to provide better care for them in our practice. One of the things when you bring up Medicaid and AAP, I think AAP is doing a lot of work with Medicaid right now, and certainly other folks who criticize them for not doing other stuff while they work on Medicaid reimbursement. We have to remember that behavioral health integration and our practices are a system, and there are plenty of things in your practice that don't necessarily pay for themselves and increase your ability to take care of your patients and see more kids. And so being able to have these kids get much better mental health care with the therapist and the child psychiatrist in my practice frees me up to see more checkups, you give more vaccines, and see more acute care. And you have to look at it as a system.
I don't disagree with you there. I'm just telling you the reality in Virginia where Medicaid pays 50% of Medicare, you're not going to be able to hire a psychiatrist to see patients, not even a block of, could you do it on Friday mornings 4 hours? They'll go, no. You know what? I get paid $150 to refill prescriptions never leaving my house. And there's just no way that I'm going to be able to make that revenue, even doing telemedicine with your patient population. I'd love to help you, but you know what? You can always call me up and I'll tell you what to do with the case, but I just cannot give up that income. And you try to get these kids evaluated where you're not sure what the pathology is. And the psychologists that are good, that are integrated, that have the reading specialist, and they do the IQ testing and the EQ, they're charging between $3,500 to $7,000 to do a study. And they get paid. They don't go through insurance. And I love to help you, but I also have a family to feed.
So one of the things, Urban, if you're getting full neuropsych testing done for $3,500, I'll send my patients to you because they'll gladly pay for the plane ticket on top of that.
Oh, yeah.
5 to 9,000. So what we did in our practice, and I think it might be Mike Chamberlain, who is partnering with the local university and has students who are working on their doctorate, their psychology degree. One of our associate therapists who is working on hours to get her LCSW also happens to be a psychology graduate program working on her PsyD. And so her supervisor for her PsyD has offered to do lower cost neuropsych testing. It's still out of pocket for the patients, but we've been able to work out how to find resources in our community. Again, this is not one size fits all. We were lucky to find a child psychiatrist who wanted to work with us, knew us. So the way the story goes is that the psychiatrist who we had been paying a cut rate on their hourly rate to meet with us twice a month by him eventually left the program that she was working in. And I said, hey, would you like to come work with us a couple of days a week? And she was willing. And could she make more money in a private practice in Marin County, which is, when you think about the demographics of Marin County, there are plenty of people who are able to pay whatever they're charging. I'd love to work with you guys. This is the point, is you can't assume that you're going to recruit someone who is in a private practice to come work with you. Those folks like being independent. They don't mind doing the scheduling and the billing, and they value the integration and collaboration the same way the folks who we've hired do. My wife is a school counselor, and we hired a school counselor. The next person we hired was another school counselor.
I'm just trying to tell you what the struggles are from somebody on the other end of the country. A wonderful psychologist, very well trained, very good at what she does. And we've been friends, I want to say, since 2000. So we've been friends for 24 years. And she is very modest, $180 for an hour of therapy. So that's very modest for my neighborhood. It's $250 to $350 an hour around here. And she tells me she's struggling. And the part she's struggling in is that she says the other members of her practice don't want to be in the office anymore. They all want to work from home.
Mm-hmm.
and they don't want to be integrated. And says, yeah, if they got to do an IQ test, they'll come in to do that, but they'll be there for the hour and then they'll leave. And he said, it's just such a different dynamic because you're not collaborating. And then the other thing she says is, it is so difficult to get the doctors. I like to pick up the phone and say, Herb, I saw Johnny. You were right. He has more anxiety than he has ADHD. And she will tell me this. I know the guidelines are not to treat him with Strattera, but you and I know that we've had great success with 3 kids with this kind of picture with Strattera. So I would vote for you to use that versus a stimulant. I'm like, you know what? You've never led me wrong. We're going to go with that. If it doesn't work, we'll think about it. He says, the doctors won't pick up the phone. And so it's a shame because, one, the relationships are very enjoyable and they smooth out the rough edges of all the other conflicts that happen in what is running a business that's more like a McDonald's than selling Ferraris. It's high volume. You're not prepared for the client because Johnny could come in with allergies or could come in with a fever or sprained ankle or this or that. It's a routine that we do in pediatrics. And so it's interesting to hear a perspective of how they feel like they're struggling. I have a question. You said you pivoted. What are...
Actually, just point out one,
Yes.
which is so much of what you just said. And I appreciate that my practice is really different from a lot of the practices out there and very different from a practice that has anywhere north of 50% Medicaid. You'll be able to see more kids and take better care of kids if you have the right support. And that support looks very different depending on what availability you have in your community. What your friend psychologist said is it's right to the heart of it. And I used to say when I started with, why is it that we hired Dr. Rebecca Timmy, our child psychiatrist? Because she was the only psychiatrist who ever sent me a note about one of my patients that I had seen. Can you imagine referring to an orthopedist who never sent you a note? Imagine referring to a GI doctor who didn't follow up with you. And yet we refer patients to therapists and to psychiatrists, so we don't know them. We've never met them. We haven't gotten any feedback from them. They've never picked up the phone to try to call us. You do have to set up other avenues, secure email or some other way to communicate. But you have someone right there who you could hire because they want to be integrated. They want to partner and they want to have a relationship with the doctors and the pediatricians who are seeing people. And can you see more patients and see more ear infections and sprained ankles to help cover some of their time? Can they bill more case management codes, conference calls? Can they do parent consults? Can they bill more screening tests to cover some of their salary? Maybe, but it's an opportunity.
I did ask her, this was 10 years ago, when I was pivoting out of the urgent care, if she was willing to come into a practice, even if it was just sharing the spaces, like being in the same building. Yeah. And we didn't have to get married. We could live together. And she was like, no, I like my office. I like the way I run stuff. If you could even just get to cohabitating, not even getting married, would be great.
The part when they're in the same building, I've seen that happen. That works well. But back to Herb saying with the Medicaid and the children, those are the ones that actually need.
They need a lot.
I'm working on a project now for some population health for one of the managed care Medicaid programs for some value-based contract. Basically making a spreadsheet of all the PHQ-9s, scoring them and putting them on the date. The amount of positive PHQ-9s, it's out of control.
Yeah.
Did these kids go somewhere? I see their note. Yeah, refer it out, but did they actually make it somewhere? I highly doubt it.
So I'm going to ask you.
I've spoken to some practices, right? Because we're all trying to talk to each other to get ideas. And I spoke to Peter in Rhode Island, whose practice has a therapist. I can't remember her licensing right now, but they see all the positive PHQ-9s. That's how the model is set up. Not what we do in our practice, but that's one way that those kids get at least assessed and provided with some resources.
So what's become such a...
What was the pivot? You said they got overwhelmed after 2 weeks and you made a pivot.
So the pivot was to, one, we had identified, okay, we've got a real need. We've got a lot of kids that we're referring to therapy who are interested in therapy. We had the advantage of having credentialed them with insurance companies. We're one of the very few places where they could get therapy covered by insurance. And so what we did is the next version is that we had her supervise a couple of trainees. The one person I already mentioned who was working on her ASW came on at that point and is still with us several years later. Someone else who was working on licensing for their MFT or AMFT came on. And so then that increased our ability to provide direct therapy hours. We also had to focus on which are the kids that really should be getting therapy from us, that we can do short term. Let's help you through whatever is happening and give you the resources, and identify those kids who really are going to need more long-term help and help them find something else in the community that's going to give them that long-term help. That was the pivot.
I think that's key, that pivot, where everybody that's been successful in implementing this, they have a limit of number of sessions they do in-house. Like they do a quick assessment. I can help you for 4 weeks, whatever the trauma is. Your parents are getting divorced or your dad unexpectedly died. You're going to grieve, and it's normal to be depressed and anxious in that situation. And we're going to help you through 4 weeks. If after 4 weeks or 6 weeks, you're not rebounding back like you're supposed to, then we're going to refer you to this trusted source, because we just don't have a bandwidth to give you therapy for 6 months because there's so many people we need to serve. But that's always, everybody that's been successful says it's a quick thing. It's a quick assessment and we'll follow you up for X number of times. If it goes beyond that, we have an external resource that we can use.
This behavioral health, has it always been here?
Where else do you think that what you did is you did your own project, Echo, with a psychiatrist. So were you meeting once a month or once a week?
We were meeting
Twice a month.
1 hour session over lunch. We would put out the Zoom link and everyone would join by Zoom from our 2 offices or from home if they were not working that day. And we've actually continued that. And so the sessions include the therapy staff. And
Okay.
we continue to do that twice a month to discuss not only new cases, but then cases that we're co-managing.
Oh, that's so awesome. And do you think there is need for that kind of system in other disease processes in pediatrics where we weren't trained? Because you look a lot younger than me, but we were trained basically, we were gunslingers, ear infections, sore throats, meningitis, pneumonias. It was just, boom, everybody's sick and that's gone. But we weren't really trained on diabetes or obesity or anxiety or depression. So do you think there's a room for that kind of model in other disease processes that are becoming more prevalent in the office as infectious disease has waned away?
I'll answer both of your questions at the same time, because George, you're about to ask, has this always been here, or is this a new morbidity? I think I may have trained a little bit after you guys, but too far. I've been doing this for a little while, and I remember the new morbidities, right? And as we started talking about, again, what was then called biopsychosocial model, and now we talk about social determinants of health. It's always been there. I tell families that may be vaccine hesitant or have a lot of questions about vaccines. I have seen in my 30-year career a huge shift in what I do and what I take care of. I'm seeing a lot less asthma exacerbations. I haven't, knock on wood, admitted a child to the hospital for asthma, and I can't even remember the last time. Ear infections. I haven't done a spinal tap in probably 15 years. Certainly haven't had a positive spinal tap. Actually, I can't say 15 years. It's been 12 years. My oldest patient who had bacterial meningitis. And so things have changed, and we now have time. I have way more time to ask kids about how things are going in school and how things are going socially. There's a lot more awareness of what's going on for kids socially. Social media. You can't have a talk about behavioral health anything without talking about social media. We had the pandemic with these kids missing out on a few years of critical social development in middle school and in high school. So yeah, George, I think it's always been there, but I do think that it's a combination of us recognizing it, having more interest and ability to address it. And also, I think things are worse for kids. I think they are.
What kind of cases do you guys?
So I just want to ask you one question before you go there. I think also what has changed, pediatrics has changed over the last 30 years, but also the pharmacology of psychiatry has changed. So if you trained before 1990, there were no SSRIs. And the idea of putting somebody on tricyclics was very dangerous. And the family practitioner, the internal medicine doctor, the pediatrician is like, yeah, they need medicine. They need a psychiatrist because these tricyclics are very dangerous drugs. And then we got the SSRIs, and that was a game changer.
Yeah, I remember when I was a kid growing up in Fall River, Massachusetts, I played street hockey. I coughed every day for months.
Yeah.
Right? I was that kid. I was coughing at nighttime. I coughed whenever I played hockey. I coughed whenever it got cold. Every cold I got went to my chest, but I didn't have asthma. Right? But if I were my patient now, I would definitely have been on some inhaled corticosteroid or smart therapy. So yeah, there are a lot more kids being prescribed these medications because we now have the tools.
Yeah, that's been
allergic rhinitis when you started your practice. Not very many, because hydroxyzine was an awful drug to put a kid on every day.
Yeah. There was in-between drug that it was before loratadine that made people gain weight. And as soon as Claritin came out, it went out of the market because it did stop your runny nose, but you gain a bunch of weight. So it's changed a lot, and it's allowed us to do things better.
Right. That's the thing when you start looking at these statistics, I would challenge anyone, if you want to look at the rise in the number of diagnoses for depression and anxiety, it's a bet that the graph and the rise in the diagnosis of allergic rhinitis in primary care has been exactly the same, because non-sedating antihistamines and SSRIs that were about the same amount of time, totally unrelated, but I think it's always been there. I certainly know that all three of us went to school with kids who nowadays would be diagnosed with ADHD or with anxiety or with depression, who didn't get help and struggled and maybe would have had an easier time of it.
And allergic rhinitis, allergic conjunctivitis. I wheezed every cold. My mother had
hard.
But yeah, you didn't go to the doctor. Are you kidding me? And she had bootlegged Bactrim in the pantry.
Yeah.
It was made by Roche, and it was white. And every time you cough, she would shake it, and she'd give you 2 days of antibiotics for nothing. And that's the way the mothers did.
We snow to get to the Bactrim, right? We walk uphill both ways.
I work from Columbia, so she would go every 2 years. We'd go to Columbia for a couple of weeks, and she had this pediatrician that saw me when I was born, and he would check you out. She was making sure everything was okay, that the American doctors didn't miss it. And he would give her a dose for Bactrim and Donatol. And she would bring 3 bottles of Bactrim and a bottle of Donatol. She didn't kill me, luckily, with the Donatol, but it was another world.
Yeah. Now, in regards to training and preparedness for a physician, I don't think we had training. I know when I came out, I was supposed to take care of ADHD. So what did I do? I read a book. Somebody showed me some stuff. There's a million patients, and over time you learned about it. Today's physicians, they don't really have training. Again, they're hesitant, I'm finding, to treat ADHD and give a little bit of Ritalin. Simple old school stuff.
And all you need is a couple of successes, right? Only a couple of kids who come back after 2 months and the parents like, oh my goodness, they haven't been able to get their homework done, or their grades are suddenly better, for you to appreciate how helpful.
I don't know in New York, right? But in Virginia, and this is Sandy Chung's work, not only do they have a Virginia mental access program, which is phenomenal, but they also have, it's free for any Virginia physician or clinician, the REACH program. You can take it in person, or you can do it online. Like online a weekend, followed by a Project Echo that lasts 6 months. And it's absolutely free to take. It just your time, right? Time is valuable, but you can do a lot of good by just going through that process.
Get that Project Reach program.
But you quit halfway because they started talking about things.
The ADHD was good. The anxiety, the depression was very good. But once they started talking into schizophrenia and OCD and all the esoteric, weird, high-level stuff, it's not going to be for me.
Yeah,
that's what they were focusing on.
Part of that, though, George, is you may not be the one that's, and we shouldn't be the one that's starting kids on these medications and getting them to where they're stable, but we're going to get these kids back from the psychiatrist. I don't know what child psychiatry is like in your neck of the woods, but I can't tell you how many times I'd get that panicked phone call from the parent that the psychiatrist is on vacation and that they have someone who's their backup who's not answering my calls and I need a refill medication. I'm glad you mentioned Project Reach. I'm glad you mentioned the Child Psychiatry Access Program that we talked about earlier, because those are the two things you can do easily and that everyone should do easily relative to having a total behavioral health and integration program. The other thing, George, to get back to folks who are training now is I think depending on where people have trained, they're going to have more or less experience with primary care mental health. During my residency, we got lectures on Munchausen's because the child psychiatrist was really interested in Munchausen's. We got a couple of lectures on ADHD, but the folks that we've hired over the last few years, we're really mentoring them and helping them learn about these medications and these conditions and how to identify. We have our child psychiatrist, like I said, set up as a consultation, right? Her job is not to follow kids forever. It's to get kids to the point where they're stable enough to come back to us for medication management and ongoing follow-up, or to decide that this is a kid who really needs a full-time child psychiatrist involved. And so we're going to refer them out to one of the child psychiatrists in our community to continue to follow them, right? To kids who may have a nuance of bipolar or schizophrenia or co-occurrent substance abuse, that sort of thing. The other part of this is like that for all of us. 10, 12 years ago, when we first started managing more ADHD in our practice, one of my partners who has been practicing just as long as I have looked at me because I had been managing ADHD for a few years at that point and said, so you just write these prescriptions for Ritalin and Adderall just like albuterol? Just like albuterol. Because once you learn the medication and you learn the indications and how to manage them, then that's what you do. It becomes part of your skill set.
Yeah, I think as a group, and I appreciate this, except for George, pediatricians are OCD. I don't know any other physician that plots the head circumference, the height, the weight, follows it on the curve, asks how many times you pooped and what does your poop look like and what's your food like. We're OCD, and it's good. That attention to detail is good for the kids because we pick up small stuff because it deviates from the average. The mental health arena is tough because there are no growth curves. There is no lab test. And a lot of it is intuition. And sometimes this happened to me twice in my career. I'm treating a symptom. I don't really know what the diagnosis is. Do you really need a blood test and a diagnosis, or are you going to let the kid develop? And with time, the diagnosis will come out. And I'm like, oh, no, I need a diagnosis. I'm writing for clonidine for this kid to sleep. And I don't know what his disorder is. I'm just treating the symptom. They're like, that's totally okay. Let's see what the kid's 3 when you start treating him. Let's see what he looks like when he's 7. He may be an AD. He may not be. He may just be a sleep disorder. But you have time. I think that's discomfort that pediatricians feel. I don't have a blood test. I don't have a growth curve. I don't know what the diagnosis is. Am I over-medicating or under-medicating? Am I doing harm by giving this kid clonidine? And that's where I think the gut turns in the pediatrician.
There are a couple of things in there. One is there aren't blood tests, but there are screeners and questionnaires and ways that you can try to objectified. And I think we've all had some screeners and seen the limitation of screening tests to make diagnoses, but you can't follow PHQ-9 scores. You can follow GAD-7 scores. One of the benefits of doing that training with REACH or having a child and adolescent psychiatry portal is that you can talk through the case with a psychiatrist and they can give you their criteria, right? This is what I used to help me decide if a child has ADD or ADHD or depression or anxiety. It can take you through the DSM criteria and ask those kind of questions that you're going to want to ask. The other that is because in primary care, I really feel strongly that this belongs in primary care for lots of different reasons. Some I've already expressed, which is that collaboration between the pediatrician and the mental health, behavioral health specialists is much better and easier when they come to our morning huddles and they talk to us about our patients when we have our consultation call. But the other part is it helps me show families and kids that there's no separation, right? When you come in for your sports physical, I care about how many sprains you've had and whether you've had a concussion, but I also care like what's going on socially and what are the substances that your friends are using and how are you sleeping and what's going on with anxiety and stress around exams or what's going on at home. It's all part of the same thing. And I do think that it takes away the speed bumps to getting help. The same place you come for your sprained ankle is where you come for your social anxiety.
It's a perfect segue to my next question. Operations and management.
Yeah.
What's the first steps that we need to do?
What does he want and what does he have the resources for? So I already went through a few of the steps that we took.
You need a social worker, right? You need patients. You already have plenty of them. You need to find a screening method of what cases should go to the social worker. Otherwise, it's just a lot of acute care.
The first thing you need to do is you need to start screening.
George, that's not the data says.
Really?
Yeah.
I don't think everyone is doing it because a lot of people are frustrated by something Dr. Bravo brought up, which is, okay, so I'm going to identify all these kids with PHQs of 16, and what am I going to do with them? In the old days, I would give them a list of local therapists, and then I'd see them 6 months or a year later, and the family like, yeah, we tried, we called, nobody called us back, nobody was on insurance. They would send me lists of people on insurance panels that I didn't recognize any of the names, none of them saw kids. It was hard. So step one might be to figure out what are the resources in your community, right? For those kids with Medicaid, what are the programs that are serving them? What's going on in the schools? Sadly, the funding looks like it might be being clawed back, but there was a pretty good wellness program in our local schools with trainees and therapists that we tried to connect with and work with. So figure out what are your local resources. Start screening. If you've already done those two things, awesome. You're already providing some behavioral health. Find someone in the community who is willing to do what we started with, right? Meeting with families and helping them navigate the system a little bit. We went from that to hiring someone. We had our child psychiatrist, as I said, who was working with us and doing consultations with us. We did the co-location thing for a little bit. That was helpful, but it wasn't all the way there. Beef up the resources that you have in your practice. I already mentioned, I'm going to share a link with you that you can put in the show notes that has a folder of different resources that we use in our practice, different workbooks for anxiety, depression, ADHD that I can give families. If you look on our practice website, again, you can link that in the show notes, has a behavioral health resources page that our therapists have put together that's amazing, has lots of great resources. I show it to families in the office every single day. And so lots of stuff that you can do that's very far short of what we've done. There's a practice that I've been on a panel with, and I'm not going to be able to pull up his last name right now, but all of his pediatricians have done REACH. And that's one of the things that in order to work in my practice, have to do REACH. Sorry, David Allen, that's his practice in South Carolina.
It was phenomenal.
Amazing.
The podcast with him.
Yeah.
Lots of great ways to solve this puzzle. And again, reaching out to local universities, all their LMFT programs that are looking for sites that they're willing to provide the supervision and send trainee therapists. In the old days where therapy was much more long-term, I think we all were a little reluctant to do that because we didn't want therapists rotating through. But Herb, as you mentioned earlier, a lot of this is really, let me teach you some CBT skills. Let me help you find some resources and build some skills around how to manage your stress and anxiety and depression. And we're going to send you out into the world and you're going to follow up with your doctor and let us know how you're doing. So a trainee program is much more appropriate in that setting.
I wonder if you use single scalable interventions at all.
Not familiar with the term.
There's a psychologist that she came from that UPenn positive psychology with Marty Seligman. And her focus of research is building, whether with web apps or applications, that a single session guides someone. And she has a great resource. I'm blanking out on the name of the website. Project Yes, I think it's called. And when someone's not feeling great, now I'm not talking about a catatonic depression. I'm talking about somebody that didn't make the cheerleading team, was feeling a little bit not right. The child can go on. It's free, and they can fill out the things. And they've shown that just that 1 hour of skill building will make a difference in how you feel. And I think it's a fascinating area because we have such a need for therapy and we can't meet it. It's called Project.
That sounds familiar, and it may be linked on our website. If not, I'll run it by our behavioral health folks to look at. But that's exactly the kind of thing that you get when you have a partnership, whether it's in your practice or a partnership outside your practice, or if you happen to be married to a therapist where you get exposed to these kinds of resources, because that, I think, increasing our ability to provide resources to our patients is key. That's number one.
Yeah.
Yeah. Finances and sustainability. This is what people want to hear. How can an office get paid to provide this service as opposed to losing money?
So this is an investment, right? This is not a line item that's going to necessarily pay for itself in most practices. If these kids are getting care and you're able to see more checkups, provide more vaccines, see more acute care, keep kids out of the emergency room or keep them out of the urgent care center, then you're going to be able to finance some of the salary of your therapist. So you got to think about this as a system. That's number one. The second thing is remembering that you will do more screeners. Behavioral health folks are doing a lot more of the PHQ-9s and the GAD-7s. And so that the income that you make from those screeners will help to pay for this program. They can do more case management and referral management. And then those codes, there are some, as I wish I knew the code off the top of my head, but there is a code that is billed under the primary care doctor so that you can get started using right away without needing to credential them. And so there are lots of ways. The link that I am going to share with you has one document that our billing office has put together that describes a lot of these codes and describes which codes can be used and how they get billed. This is not a document that we're not giving billing advice, but it's a great place to start for folks to look at those codes and figure out which ones might be appropriate for their setting. And then to have someone on your billing staff or your administrative staff who is keeping track of that stuff is really important. The other part of this is going back to your payers and saying, look, we're integrating behavioral health, and so we need to figure out what we can do around these codes, and can we negotiate better payment. The financial stuff is tricky and the billing stuff is tricky. Number one pitfall is, can we afford this? Number two pitfall is it's complicated. Credentialing, and does this billing go to the insurance or does it go to the mental health carve out? And now suddenly I've got to start dealing with these Magellan people. We're in a CIN, and so our credentialing goes through our CIN, and do they credential LPCCs and do they credential LMFTs? And so there are questions that need to be asked and workarounds that you have to figure out. Some of that, my slides from some of the presentations I've given are in that folder I'm going to share, and so feel free to look through. The big, and we danced around this a little bit during this talk, is this mental health and behavioral health for a pediatrician who doesn't have resources to provide and doesn't feel prepared to address it is a huge factor in burnout. And whether you call it burnout or you call it moral injury or you call it frustration, I very clearly remember several weeks ago, I showed up in the office and I opened up my schedule. We're not a super high volume practice, but my day, I had 15 kids scheduled with lots of gaps for acute care. Obviously, I wasn't going to end with 15, but I started with 15, and 9 of those 15 were ADHD, anxiety, school problems, some behavioral concern. And my experience on that day is not that different from the experience of most pediatricians. And we're seeing a third to a half of the kids on the schedule are coming in for a primary behavioral health diagnosis. They're coming in for checkups, their yearly checkups, and there is a mental health diagnosis. I practice in Marin County. We already talked about the demographics of my practice. I just finished doing 2 weeks locums in Arizona on the Navajo reservation in a town called Pima City, which could not be more different from my practice in Marin County. But the issues were exactly the same, just to a much, much higher degree with far fewer resources. And so this is everywhere, and it's leading to a ton of burnout. All 3 of us practiced before hospitalists, right? You remember leaving the office in the middle of the day to go to a C-section and standing there while the tracing got better, and then you'd run back to the office and there were patients who had been waiting for an hour and a half because you were at the hospital for the C-section or resuscitating a baby and getting them stable. How happy were you when you suddenly could stay in the office because there was somebody who knew what they were doing, who could take better care of that baby because they were doing it every day and took care of it at the hospital, right? Your patients got better care. You did what you did best, which is just doing checkups and vaccines and acute care, and you could sleep at night. Having behavioral health integration is going to help me recruit the doctors. It's going to help me keep doctors. It's going to help me practice longer, and it's going to provide so much better care for my patients. If that costs me a little bit every year, then maybe that's worth it, right? And I'm trying to dismiss that this is really financially challenging for practices with a lot of Medicaid, but how much money and time do you spend recruiting doctors or having doctors who need more time off, who need more dedication time, or retire? How would the rate of early retirement after the pandemic? It was significant.
Yeah, the average pediatrics is a women's specialty now. I think some like 80% of graduating residents are women. And they're lasting, the average about 7 years post-residency, and then they quit. They don't want to have anything to do with the examiner, which is just alarming because all the resources that have gone into creating a pediatrician, and all of that is just lost in 7 years. And of course, it's every week. You walk in, 3 kids with physicals. The one kid, the twins, a 6-year-old, one's got asthma and was extremely premature and snores at night. The male twin bounces off the walls. And when you tell the mom, is he having trouble in first grade? Nope. Are you getting called because he's not completing his assignment? Nope. Is he disrupting school class? Nope. So he just behaves like this at home? Yeah. I'm like, then it's a discipline problem. You got 6 kids, no car, no money, no job. You're doing the best you can. Until the school complains, we don't need to address it. And she started crying. I'm like, oh my God, what did I do wrong? She's like, all their kids are calling him autistic. I'm like, no, he's hyper. He's hyper. But if it's not causing problems in what his job is, which is school, and you can deal at it from your perspective at home, we don't have a problem. He's growing. He's getting the best we can do. And then the next kid, the teenager, 300 pounds, BMI 40. Of course, PHQ-9 off the charts. not going to school.
And
And that's those three scheduled at once, right? And it's like, George wouldn't care. He would just walk out of the room like, not my problem. But for most of us, you go home and your heart hurts and your head hurts. I'll order the labs. He's probably pre-diabetic. I know I can't put him on a GLP-1 because Medicaid won't pay for it. What do I address before his struggle with weight or his depression, or is he depressed because he's obese? What do I do about his school avoidance, which was hurt by, you said it, I laugh at social determinants of health. We've known that whatever your social circumstance is affects your health because the number one determinant of how long you live is your zip code. And that's been around for 50 years. Okay, so let's just stop with the fancy terms, right? I'll order the labs. I'll see you back the next time I'm in clinic, and we'll try to sort out, depending on what your metabolic profile is, which direction we can go. But we're limited in every direction because if I send you to, I'm going to rag again on the AAP, which is incredibly obtuse. There is no way this mother with no car, 6 kids, is going to be able to take this kid once a week for 45 minutes to no clinic to get behavioral interventions for 6 months to get his weight under control. That's not going to happen.
why is that an AAP problem?
No, that's their guidelines. Look at the guidelines. That's what the guidelines say. So what can we do?
The point of the guidelines are for you to take those guidelines to other people in your community to say, look, this is what's recommended as appropriate treatment for these kids. And so how are we going to create that resource in our community? Do you know who else has a 7-year average career? Pediatric ICU docs.
Oh, I can't imagine.
And that's what you're describing is you go home and your head hurts and your heart hurts. Absolutely.
But at least we get to sleep. The ICU doctors don't get any sleep.
But it doesn't matter. Your head hurts and your heart hurts. And after 7 years, it doesn't matter if you're a woman or you're a man. It doesn't matter where you trained or where you grew up. You continue to provide care if you feel like you're able to make a difference. And so, again, I like the hospitalist analogy because for me, hospitalists, the generation, I was still pretty young in my practice when I started practicing in a place with a hospitalist. It was within the first 10 years of my practice. But I did spend a lot of time trying to deal with kids who had mental health concerns that I didn't feel equipped to care for. I've seen both of those revolutions in my practice. And so that's why any invitation to talk about behavioral health integration, I'm there.
Yeah. Just for the record, I've never been to C-sections in a practice. I missed that. I'm not that old. I don't think Herb either.
No,
From the office?
Yeah.
Wow.
You don't have to be that old. It just depends on where you're from. And again, I was lucky that I moved into a private. One doctor of the team assigned to do that.
Offices were open from 9 till noon. The reason that you opened the office at 9 is because people did rounds before they came into the office.
Right.
So you showed up at the hospital around 7:30, went over the newborns, the kids on the ward, and then you went to the office. Then at noon, you went back to the hospital to see how the hospitalized kids were doing, see if anybody needed to be discharged. The labs were back. And then you saw the kids in the office, and then you went back to the hospital before you went home to see if there's anybody else that needed to be tucked in before the night was over. And unfortunately, some people that are not making money now are people that started that model, and that doesn't work anymore because you don't have any of the income from the hospital, so you can't take 2-hour lunches.
The other side of that is eventually you're the best person to take care of that kid in the hospital because it's not simple dehydration because we're
Not anymore.
Yeah. Mild asthma exacerbations because inhaled corticosteroids have taken care of that. It's not bacteremia or with strep pneumo because Prevnar and vaccine events have taken care of that.
Yeah. I think the kids with mental illness are less sick in some degrees because you don't, like in residency, to your point, your psychiatrist only talked about Munchausen's. At Chicago, we had a locked ward for kids with really bad mental illness. The only reason the peds resident went down there was to do the HMP when they got admitted. And you hate it when there was that month out of the 3 years you had to do it. and you got out of there as fast as you could, and you didn't want to be there for any amount of time. But with outpatient therapy now, you can keep some of those kids from ending up in those locked wards, which is phenomenal. But it means you got to learn, you got to put the system into the practice. You got to be willing to take a little risk and be patient. These things don't change overnight.
And I think the goal of this whole thing is that eventually we start doing a little more preventative behavioral health, right? More parenting support, parenting classes, resources for kids in the elementary school and middle school years. The schools do a lot, but there's a lot that we can add to that in pediatric practice.
Thank you very much. I think this was a very fascinating topic.
Phenomenal.
Great.
Have a good
Thank you for your time, and
Thank you.
it's great meeting you online.
Me too.
All right.